Are you connected? Are you informed? Get in the know and keep abreast of what you need to know. Community Health, hosted by Alvin Simmons. Join him. Get informed with Community Health on V100.9. Welcome to Community Health. Community Health is it is designed with you in mind, talking about issues valid to you in your community. Today, of course, is our host, as always, Alvin Simmons.
Hi, this is Alvin with Community Health, your locally broadcast program about the health events in the state. Our sponsors are the University of Arkansas for Medical Sciences, Habibis Incorporated, and AFMC, Arkansas Foundation for Medical Care. If you would like to become a sponsor, please drop me a line. We will be back with the health announcements we have thus far.
This is Dr. Chad Rogers with your AFMC Health Minute. The interesting thing about this virus, it's not just about me getting the virus, but it's also about protecting others from getting the virus. And I think that's more important than sometimes trying to protect yourself, because that senior population is so vulnerable and they're more likely to get hospitalized, they're more likely to go on a ventilator, and they're more likely to die. So I think it's really important to think about your neighbors, think about your family members, think about the people even that you don't live in the town with but you know are older, to really reach out to them, to give them a phone call, to make sure that they're doing well, to make sure they have the things they need, and maybe ask them how you can help them.
Did you know video series from the National Cancer Institute, Colorectal Cancer. Did you know that in the United States, colorectal cancer is the third most common cancer in women and the third most common in men? Colorectal cancer is cancer that begins in the colon or rectum, which are both parts of the large intestine. Colorectal cancer represents 8 out of every 100 new cancer cases. Symptoms of colorectal cancer include changes in bowel habits, blood or changes in the appearance of bowel movements, pain and bloating, unexplained weight loss, vomiting, and fatigue. Risk factors for colorectal cancer include older age, alcohol use, cigarette smoking, obesity, a personal or family history of colorectal cancer, a personal history of certain types of colorectal polyps or inflammatory bowel disease, and certain inherited genetic changes. This cancer is more common among men than women, and is more common among blacks than in other racial and ethnic groups in the U.S. Even though the overall incidence of colorectal cancer has declined over the last couple of decades, both incidence and death rates of colorectal cancer are increasing in younger men and women, that is, those aged 20 to 49 years. 5-year relative survival for colorectal cancer is 64%. This means that out of every 100 people who were diagnosed with colorectal cancer, 64 have not died from their cancer in the 5 years since diagnosis, after adjusting for other causes of death. Researchers believe the increase in survival is likely due in part to new treatments as well as increased screening. Colorectal cancer screening helps doctors find colorectal cancer early, when it may be more treatable. Some screening tests also detect abnormal colorectal growths, allowing them to be removed before they even develop into cancer. Colorectal cancer screening has been shown to reduce deaths from the disease. If you have a family history of colorectal cancer or are age 50 or older, talk to your doctor about screening. For answers to your questions about colorectal cancer, visit cancer.gov or call 1-800-4CANCER to connect with specialists from NCI's Cancer Information Service.
For the general population, the screening age begins at age 50. For the African American population, it begins at age 45.
I had no idea that African Americans were supposed to be screened at a younger age than the general population. I didn't know. I'd always heard the number 50.
The statistics show us that in the African American community, we develop colon cancers at an earlier age.
African Americans have a 20% higher risk of colon cancer and have a 45% higher risk of dying from colon cancer.
Despite the overwhelming benefit of screening colonoscopies, it's noted that only 63% of African Americans are actually being screened for colon cancer.
My message is stop tripping, go get a colonoscopy, whether you are 45 years or older, or if you have symptoms.
Come in for colon cancer screening because this is the test that's going to make a difference in your life.
We're not proctologists, but we do examine and treat patients with diseases of the GI tract. That's the esophagus, stomach, intestines, large intestine, pancreas, liver, etc. So I'm a gastroenterologist, and I see patients, my area of specialty within gastroenterology is dealing with colorectal cancer. I see young patients like some of you sometimes in my clinic because you have a strong family history of colorectal cancer. I'm a gastroenterologist and I like what I do. I also love football, okay? And you guys recognize this place, right? It's down the street, yes? So this is U of M Stadium. And you see this little yellow group in the northwest section? That's you guys, right? Okay? So big student population, everything. This is the big house. However, this stadium represents something that deals with colorectal cancer. It takes this stadium plus another third of this stadium to represent the number of people who get colorectal cancer in the United States. It's a lot of people. This stadium holds 109,901 people. And half of this stadium dies every year from colorectal cancer. Okay, so why do you guys care about it? Because even though you guys are in the northwest section, there's some of you that will get colon cancer even at a young age. The majority don't, but there's some that do. And also, the precursor, the colorectal cancer just doesn't happen overnight. You develop a precursor lesion we call polyps, such that the things that you eat and some of your background genetics affect the growth and that polyp to develop. By the time you're age 50, a quarter of us will have polyps in our colon. Okay? It's a pretty common disease. Now, this is so important, we want to detect them. We've invented more than 7 ways to detect polyps in the colon. Some of them are shown on this slide. We have ways to use contrast to show the large intestine or colon. We have tests in which you take small samples of your stool, and your parents probably have done this, and sent them into the doctor to determine if there's evidence of blood or any genetic material in the stool. We sometimes even use CAT scans that can detect polyps. These are all detection tests. All these tests also have variation on their accuracy. Some of them are less accurate than others, but all of them have been shown to actually save lives for the most part. And there's variation in the test costs. Some of these tests cost as little as $5 or $6, all the way multiple thousands of dollars. Now, all the tests I show you on this slide are detection tests. They hopefully find things. Ultimately, all of them lead to a test we call colonoscopy. Colonoscopy has emerged to be the most preferred test by gastroenterologists. It's an awesome test, okay? As a gastroenterologist, you use a flexible camera to go up the rear end and look through that large intestine. So it not only detects things, but we can actually sample and remove them. So it's a diagnostic and therapeutic test. But it does require the patient to do some extra things. You have to take out a clean out solution. So it's a large amount of fluid that you should take usually the night before or the day of to clean yourself out. How many of your parents have done this? Oh, they groaned about it, I'm sure. That's the worst part. You have to take a day off from work because we usually give you sedation for this test. And it's usually 2 people who have to take the day off from work because not only the patient, but you as the driver, as their son or daughter. It also has some risk. There's a risk of bleeding or infection sometimes, and there's some of that's been in the news recently. But there's also a small risk. About 1 in 1,000 can have a perforation, which means accidentally poking a hole through the colon. Irrespective of that, it's still the best test. It has emerged as the gold standard for detecting and removing those precursor lesions we call polyps. Okay? Because it's the preferred test, and it's the test recommended by most of the gastroenterology organizations out there, how did it get to that point? There are a number of items to consider that bring that test as the most valued test to gastroenterologists. First, I mentioned the cost. There are federal guidelines by an organization called the U.S. Preventive Task Force that looks at cost of tests and how effective is that cost for saving lives. And colonoscopy, despite its expense and its risk, is very cost effective. How efficacious? It's the best test. It's our gold standard for detecting polyps and cancers. There's been so much studies that's led to guidelines for when do we start screening patients and how we use this test. The performance, as I said, is the gold standard. And there's some safety, as I brought up, even with 1 in 1,000, it's still a fairly safe test with those caveats of risk. So that efficacious, that amount of the safety profile, irrespective of what I said before, still leads value to detecting these things at an appropriate time point before it turns into cancer. What is the standard time for us to get screened? In the absence of a strong family history or a high-risk condition, the average age for screening is age 50 years. And generally, if that colonoscopy is negative, meaning no polyps or cancer found, you don't need another test for 10 years until age 60, etc. That accounts for 2/3 of all the patients in the country. So 2/3 of patients will fall under that average risk profile, starting at age 50, getting something 10 years later. If you're high risk, such as shown by this family tree, if you have a large number of family members in your family tree that have had colorectal cancer, for instance, that screening may happen earlier. So that's the exception. But for 2/3 of the population, age 50, every 10 years. Now, prior to around 2001, the use of colonoscopy was probably ad hoc. 2001 was the first time Medicare, which is a government agency that funds health insurance, paid for colonoscopy. And certainly when stars advocate, people listen. Anyone recognize who's on this screen? That's right. This is Katie Couric. Her husband died at age 43 from colorectal cancer. He was one of the unfortunate young people, even below the age 50, because he had a strong family history. But after Katie got over her grief, she went on national television as one of the leads for the Today Show and had her colonoscopy performed on live TV. Okay? That resulted in the year 2000, before Medicare paid for it, a 20% rise in colonoscopies. 20% by one person. That's amazing. So driving up awareness is excellent. However, some issues could drive the inappropriate use of colonoscopy. From the patients, and I should mention that in this country, we spend $3 trillion in healthcare costs. And it's estimated at least 10%, or $300 billion, is excess costs from abuse and overuse. What are some inappropriate drivers of cost? Well, from the patient's perspective, you're bombarded. I'm sure this show is being tweeted all over the place. But you're bombarded sometimes with good information, but sometimes unclear or misleading information, leading to trying to get these tests at a more frequent interval. You may hear that your friend had cancer, and certainly you should have yourself evaluated but you're not related to that friend. But sometimes that drives tests as well. Am I clean or clear, or overinterpretation of your family history might drive this. So getting the correct information is appropriate. From the doctor's perspective, fear of lawsuits, capitulating to those to ease the fears of patients, doing something habitual without consulting or learning about updated guidelines for the use of colonoscopy. In a physician's case, sometimes overinterpreting family history could lead to excess colonoscopy. And sometimes the financial incentives are not properly aligned, even between physicians and insurers for the use of colonoscopy. So what has happened? Insurers, like the Centers for Medicaid and Medicare Services or other insurers, are starting to mitigate costs. Did you know that the cost of a colonoscopy in a hospital might be different than the cost of colonoscopy in an outpatient endoscopy center? Did you know that? CMS does, and they're trying to mitigate and even out those costs. What if the endoscopy center uses an anesthesiologist? Every colonoscopy doesn't require an anesthesiologist. That drives up the cost. So CMS and other insurers are talking about bundled payments. That is, payments to the doctor or the hospital for everything involved with the colonoscopy, whether you want to use an anesthesiologist, a pathologist, or whatever, and you decide who's going to keep that money. So they've gotten involved. Companies have gotten involved. I have a picture here of Safeway grocery stores. Back in 2009 and 2010, Safeway was looking at the cost of insurance to their employers. And then the health care insurance was going up too fast. So they looked at a number of procedures, including colonoscopy. And in particular in the state of California, they did a survey, something we call price transparency. And if you looked at, 200, 300, 400 places that did colonoscopies in California, they found the range of $1,200 to $8,000 for the identical procedure, okay, no matter where you went. And so they took a median of that, which was like, let's say $2,500. And they told their employees that you can get your colonoscopy anywhere you want as long as it's $2,500 or less. Guess what happened? The guys that are charging $8,000, they were losing some patients, they dropped it down to $2,500. So companies can control costs. That is called reference pricing, by the way, and that's becoming more and more commonplace in the medical record. Now, you may say, what does this have to do with me? Well, a lot of you raised your hands about your parents getting colonoscopy. Now, if they went to an $8,000 place, okay, and said, oh my goodness, I have to spend my excess money instead of on your tuition, you'd say something about that, okay? Science has gotten involved as well. Science has shown that if you have an initial negative colonoscopy, let's say at age 50, and there's evidence that 10 years later, if you offer another colonoscopy, which is $2,500 test, let's say, or if you offer a $12 test, such as one of these others, you may have the same number of life years after that. So it may not make a difference as long as your initial colonoscopy is negative. So you should learn, ask, get accurate information. Knowledge is power. The American Board of Internal Medicine, which certifies internists and gastroenterologists like me, has started a campaign called Choosing Wisely. It's a way to educate physicians and hopefully their patients about correctly picking things based on guidelines or evidence-based medicine. And this campaign was started just a few years ago. The idea is to take something like colonoscopy and give you the best cost and value to you and your parents, your aunts, and your uncles. I'm going to close by saying March is Colorectal Cancer Awareness Month. The best test for you and your parents or anyone who's appropriate to be screened is the test that gets done. All of those tests I showed you are still cost effective, and colorectal cancer still kills people. And you You should recommend to your aunts, uncles, parents, if they're over the age 50, they should get screened. And if you have a strong family history, you should talk to your physician or go over to student health and find out more information and pass that information on. But colorectal cancer still is the second leading cause of death in the United States, and 1 out of 3 people still don't get screened. So pass that information on. Thank you.
To us about colorectal cancer screening in the community, let's welcome Dr. Joseph Ravenel, who is an associate professor in the departments of population health and medicine, and he is also the director of diversity in research here at Perlmutter Cancer Center. Let's welcome Dr. Ravenel.
Good afternoon, everyone. It's a pleasure to speak to you today. Thank you so much for taking time out of your day to come. March is one of my favorite months. It's my birthday month, but it's also a month that we get to talk about colorectal cancer, which is a cancer that we know is preventable with timely screening. Unfortunately, there are inequalities in the rate at which different populations are screened, and there's a whole list of reasons for that, but we're going to talk about some of our efforts here at NYU to essentially address some of the disparities that we see in colorectal cancer screening. So you guys have probably seen something like this slide a couple times today, but it shows that basically when you compare the death rate from colon cancer in Black men compared to that in white men, that Black men are significantly more likely to die from colorectal cancer. In fact, Black men have the highest death rate from colorectal cancer compared to all the other groups in the U.S. And we believe that's due mostly to lack of timely screening. We can talk a lot about some of the reasons for that. One of the major ones is access to screening. And by access, I also talk about insurance coverage. Often to get screened for colon cancer, it's not cheap. And so if insurance coverage is an issue, then screening is going to be a challenge. But what we found through some of our research is that one of the big barriers is knowledge, and people knowing, and Black men in particular, knowing that they have an elevated risk of dying from colorectal cancer. So many of our efforts focus on educating Black men about the special implications for colorectal cancer for them. So when we look at colorectal cancer screening, we start here for men who are eligible to be screened for colorectal cancer. And while there are kind of shifting guidelines about who should be screened, the United States Preventive Services Task Force recommends that everyone who is of average risk be screened at age 50. The American Cancer Society recently came out with guidelines that actually suggest that everyone who's of average risk be screened at age 45. But even when someone is of screening age, there are several steps to actually successfully getting screened. So first, the person has to be connected with the healthcare system. There can be barriers here to men even seeking care. Then once they're in the healthcare system, the provider or the doctor actually has to make the recommendation. Believe it or not, there was a time when not all physicians recommended colon cancer screening for people who were of age. And once that problem came to light, we did a much better job of ensuring that we let our patients know about the need for screening. But even once the recommendation is made, once the colonoscopy or other screening modality, once the referral for screening is made, then there's a matter of making the appointment, of completing the prep. If you choose to do something other than colonoscopy, having access to those tests. So not only getting those, but then correctly completing those tests. All those are really important steps that have to be done correctly in order for a good screening test to be done. And one really important point is, if you're doing a screening test other than colonoscopy, if that test is abnormal, you have not been screened until you actually complete the follow-up colonoscopy for that abnormal test. And so if you're using a FIT test or some other kind of stool card, if those tests are abnormal, then you have to follow up with a colonoscopy. And we believe that screening is not complete until you actually do that follow-up. It's not an easy process by any means, getting screened for colorectal cancer, but there are definitely steps along the way where we can try to target how we can improve the adherence to this process. So one of the major contributors to lack of timely screening among Black men, as I mentioned, is access. This is data from when I was in Dallas, Texas. This was a population-based study of over 6,000 people, and what we learned is that Black men are less likely to have a primary care doctor, again, for a whole host of reasons, but that can be an extremely important barrier to getting referred for colon cancer screening. So we started to think, if we're not having success reaching Black men in clinical settings, what are other ways that we can reach them? So the barbershop is a place where I started doing work about 15 years ago, drawing on my own experience growing up and going to the barbershop with my father and realizing how important a part it was in terms of being a part of my life. It's a place where men go for friendship. It's a safe space where you can talk among your colleagues, talk with your barber about just about anything. And healthcare is often a big topic of conversation in the barbershop. And we showed in Dallas that if we can have barbers talk about high blood pressure and actually measure blood pressure or encourage men to get their blood pressure measured and treated, that it was a very successful way of getting men to take care of this very important condition. So when I started here in New York City, the thought was, well, if the barbershop was a good place to talk about hypertension, high blood pressure, it might also be a good place to talk about cancer screening, and in particular, a cancer that has special significance for Black men because they have the highest death rate from it. So why barbershops? It's often affectionately known as the Black Man's Country Club. It's a relaxed, non-medical atmosphere where men can spend lots of time. It's a place where some men go as often as once a week. The barbers are well-respected members of the community often. And here in New York City and in other states as well, barbers actually have to go to barber school to be licensed, and you have to be actually licensed in order to be a barber here in New York State. Part of their training in school includes a component of healthcare, and so the idea of promoting health and talking about health is not a foreign concept in the barbershop. And I've heard many men say that they trust their barber more than they trust their doctor. And if you think about that, it's not outside of the realm of possibility. If you're going and establishing a rapport and a relationship, once a week or twice a month, every year for 7 years, which we believe is the average that Black men have been with their current barbers, that you build a much more intense and trusting relationship with the barber than you do with a doctor who you may see 2 or 3 times a year. So we asked the question, when we think about the problem of high mortality rates from colorectal cancer, yet lower screening rates, can we identify unscreened men in the barbershop and essentially navigate them to where they can be screened for colorectal cancer? So we replaced the doctor's office here with the barbershop, with the idea that basically a patient navigator can actually act in this space to actually help to escort or navigate men into the healthcare system to ensure that they get the care that they need. So we started the NYU Men's Health Initiative almost nine years ago, and we were very fortunate to get funding from the National Institutes of Health to actually do a series of projects. One was based in barbershops, one was based in churches, and excuse me, basically what we did was we went to barbershops, identified men who were unscreened for colorectal cancer, and they were randomized either to be connected to a patient navigator or to receive usual care, which was just printed information about where they could go for colon cancer screening. And we followed them for 6 months and looked at the end of it to see which group of men had a higher screening rate. So the patient navigation intervention that we did, it was typically multiple sessions. For the first session, the patient navigator, who was, we worked with several over the duration of the study, and the patient navigators were people that we hired from the communities that we were working in. We were working primarily in northern Manhattan and Brooklyn, and so we were sure to hire patient navigators from those parts of the city. So the first session was an introductory session where often what we did was just acquaint men with their risk of colorectal cancer and to let them know that they had a higher risk of dying from colorectal cancer than any other group. And then in that first session, we also tried to figure out what were the barriers to men getting screened. There were at least 2 or 3 other sessions that followed that over the 6-month period, where the navigator would revisit barriers, but really would focus on what are the things we need to do to make sure that this man gets screened in a timely way. So we were very fortunate to work with over 200 community partners all throughout the city in all 5 boroughs. We focused primarily on barbershops, but we also were doing work in churches, several social service organizations, mosques, and other community-based venues. So this is some data from the men that we encountered in the barbershop. On average, they were 55 years of age, which is just the age that we wanted, although ideally we would focus even younger and try to get men to get screened even closer to the age of 50. The majority were born in the U.S. The majority spoke English at home. Only 25% were married or living with a partner, and that's important because we know that a big part of the success of people getting screened has to do with who is in their corner, encouraging them to go get screened and helping them, with whatever they need in order to get screened. And so sometimes not having a partner can be part of the barrier. So it was important for us to note that. This was closer to 2008 to 2009 when we first started the study. And so there were huge economic challenges in our country, but I think the men that we were working with were really impacted by that. And as you can see, household income of $17,000 a year. A very high smoking prevalence we also found, and it's something that we are looking at how to address as well. So along the way, we tried to assess what some of the barriers to screening were, and by far the biggest barriers were lack of knowledge about colorectal cancer, as well as colorectal cancer screening, and then risk perception, basically men not believing that they were at risk for colorectal cancer. When we looked at the major facilitator of screening, as reported to us by the men who participated in our study, if they prioritized prevention or thought that was important, that was a big facilitator of them deciding to get screened. So after 5 years of this study, we basically saw that the men who were connected to patient navigators in the barbershop were about twice as likely to get screened for colorectal cancer compared to people who just received a referral from their doctor. So this was a hugely successful study for us, where we essentially, doubled the rate of colon cancer screening with the intervention of putting patient navigators in the barbershops. Now, we still have a ways to go because, as you know, the national target for screening rate is closer to 80%. But when you consider that all these men at the beginning of the study were not screened, we're happy with the success that we had. But we're working now to see how we can improve this number closer to the national targets. I think it's also important to note that when you look at the literature on patient navigation, the literature often focuses on navigating men from the primary care doctor's office to the colon cancer screening test. We were talking about navigating people from the community to the screening test. And so when you consider that many of the men that we encountered didn't even have primary care doctors, we were happy that we were able to connect many of these men. So the take-home results from our study are that participants who received the patient navigation intervention, where they met with the patient navigator in the barbershop, they were twice as likely to get screened compared to those who just had a usual referral from their doctor. And when we looked at whether or not insurance played a part in how effective our intervention was, we found that even when we controlled statistically for insurance and for health literacy, the intervention still remained effective. And so what that means is, regardless of whether you had insurance or regardless of what your level of health literacy was, we still had success in navigating people to successful screening. We worked with an incredible group of navigators and community members. We actually asked our navigators kind of what were the strategies they used for reaching over 700 men in the barbershops. Kind of interpersonally gifted navigators, identifying the right neighborhoods, going to where the highest needs are, to those neighborhoods where you're more likely to find people who have not been screened, and that sometimes takes some work. Actually on foot, traversing different neighborhoods and finding where the right places to be are. And then persistence, right? Not just, when you encounter someone who hasn't been screened but who needs to be screened, kind of not just taking no for an answer, but continuing to educate them and to encourage them to complete this life-saving screening. So we're very happy to have been part of the movement in New York City, where essentially the disparities in screening have largely been equalized over the last 10 years or so. And when you look back in 2003, where there was a significant difference between the screening rates of Black men and white men, by the year 2013, which was right when we were doing our work, you can see that the race had equalized. So we definitely take some ownership of being part of that. And then here is how New York City fared in terms of increasing their screening rate to almost 70% over that time period. And importantly, the mortality from colorectal cancer actually decreased for all groups over the early part of the 2000s, when this work was happening. So this work has led to other patient navigation programs. We now have a cancer prevention navigation program here at NYU that includes both navigation for colorectal cancer screening, but also for breast cancer screening as well. And we've just embarked on projects that focus on navigating community members for screening for other cancers as well. So this work in colorectal cancer has been very important for our approach here at NYU for reaching the community and helping them to complete screening. We also here at NYU we have a very active Department of Population Health, where we actually look at how we can help a multitude of communities. And one of my colleagues, Dr. Nadia Islam, she actually does work in the Asian community, and so she recently published some work looking at data from 2013 to 2016, looking at people who are eligible for colon cancer screening, and basically found, and this is data that comes from the New York City Department of Health, found that South Asians in New York City are significantly less likely to have had colon cancer screening over this time period compared to other groups. So Dr. Islam and her team are really working hard to find approaches to really reach out to this community and really try to
Black Health Now. Flu viruses are detected year-round in the United States, but they are the most common during the fall and winter. The exact timing and duration of flu seasons can change. It often begins to increase in October, peaking around December through February, and occasionally it lasts as late as May. Did you know people with flu can spread it to others up to about 6 feet away? Experts believe flu viruses primarily spread through droplets made when infected people cough, sneeze, or talk. When we inhale these droplets into our lungs, they can land in the mouths or noses of others who are nearby and make us targets for infection. This season, help stop the spread of flu. Remember to get your flu shot, cover your coughs, and keep your hands clean. This is Erica Monet Bram for Black Health Now. Black Health Now.
Every 10 years, the census comes along, and it seems like everyone I know always asks the same 2 questions. What is the census, and why does it even matter? Let me give it to you straight. The census counts every single person living in America. An accurate count of our community tells us where there are more people. And where there are more people, there are more needs. Our participation could impact how public funding flows to our schools, health clinics, senior care, job training, and housing. It even determines our congressional representation. I don't know about you, but it sure sounds like the census matters to me. This year, take a little time for the 2020 census. You can complete it online, by phone, or by mail, and make sure you count everybody you live with. Your mama, daddy, sweetheart, babies, roommates, everyone. This chance only comes every 10 years, so let's step up and be counted.
Shape your future. Start here. Learn more at 2020census.gov. Paid for by U.S. Census Bureau.
This is Alvin with Community Health. We want to thank our sponsors again. Our sponsors are the University of Arkansas for Medical Sciences, Habibis Incorporated, and AFMC, Arkansas Foundation for Medical Care. If you would like to become a sponsor, please drop me a line, either email, text, or a phone call. We thank you for participating.